Welcome, Doc, to another call this morning. So let's get to it. Today's today's topic is on Mpox. So for our audience, today's topic is on modeling diseases and Mpox. And we have this I can say newspaper article by Daily Nation that was released in the 2nd of April 2026. The headlines read Kenya now Africa's deadliest Mpox hotspot as outbreak spreads to 38 counties. So, Doc, I know one of your counties here is listed among these counties. So, I think just from the paper, they were saying that 4 of the 7 Mpox deaths recorded across Africa between February 15th and March 1st were in Kenya, making it the continent's deadliest hotspot in that period, according to World Health Organization, WHO, situation report that also placed the country third among nations with the most active cases. Yes, and from that opening, I think that's where we decided, okay, Mpox might be really a good thing to look at right now, and even just introduce modeling, because I think we'll be covering more modeling stuff as we go along in this podcast. Yeah. So, any words or two, Daktari, before we dive deep?
No, maybe we could we'll just like you said, we'll touch on the background a bit, touch on modeling of diseases, and then the essence of modeling. Why do we do it? And we'll use Mpox as our case study in this matter to see how modeling happens. Yeah, I let's go.
Yeah, great. So in this case, they were saying in early 2026, 4 of 7 African Mpox deaths were happening in Kenya. And I think that's where the aspect of deadly comes in. So just to put matters into context. And this, I think this speaks to I think we'll talk about this more as we go on, but the mortality rate for Mpox. It's not really a fatal disease that I'd say, but when you see things such as 4 of 7 African Mpox deaths happening in Kenya, then my internals sort of start tweaking, and I'm like, okay, something is happening somewhere, and I need to figure out what's going on. So in this period, 1,065 confirmed cases across 38 African countries, and this is happening after Mpox was declared a continental emergency all the way from January. So now, from this headline, it's like Kenya is the epicenter. So why Kenya? What kind of models can we use or people are using at this point? I think this falls in the space of epidemic, but we'll get to it more and see how that shapes up over there. Yes. I think for our audience who are not familiar with Mpox, it used to be called monkeypox, and it comes for a group of viruses. It's a autopovirus, and it's within the same family as smallpox. Yes, autopox virus. So it comes within the same family as smallpox, vaccina, those kind of viruses. I think many people might be aware of smallpox, which uh, which was not, can I say, eradicated?
Mm.
Yes. So it has.
And funny enough.
Mhm.
Yeah, it's okay, it's okay. Just
Go on, Doc. Yes.
I w- I wanted to highlight the background of it. It was first isolated in 1958, the research lab of monkeys, and then it was never categorized or even thought of as a human infection until the 70s, when during the smallpox eradication campaign, it was discovered in DRC. Yeah. So then from there, it has been on the WHO radar in a way, so to speak, to date. Yeah.
Yes, and I think from that campaign is where now they got the clade 1, which was higher severity within that region. And also we went to clade 2 within West Africa. So that for the West Africa, clade 2 happened around 2022, about there. And now we are seeing this particular, I can say, strain or variant, Clan 1B, now happening particularly in Eastern Africa. So where now Kenya is coming into play, and we are seeing these cases happening in Kenya. So by Clan 1B Mpox, simply this is a newly like emerged, highly transmissible and more severe variant of the other Mpox. So that's why in this case maybe so we are seeing the 4 out of 7 deaths having been reported. Yeah.
Yeah, but I think by 2022 we had over 100,000 cases reported. Uh, when was it? Last year. Last year around I remember well, July, August thereabout. Uh, we I think as Kenya we got our first few cases, majorly due to I don't know if you have talked about transmission and symptoms, but we'll cover that later. But due to its nature of transmission, which we'll see, a lot of these long distance truck drivers from our neighboring countries uh, fell victim. They were patients of this illness or virus, and that's how I think it got to Kenya because it's so common. It's arose almost simultaneously along our border points. That is Busia and Mombasa as well. So I think from DRC, Uganda, I don't know if Tanzania had it, but Rwanda, I think, also had registered a few cases. I can't really remember the numbers, but these were among the first countries to go ahead and report that they have these cases even before us. Then, after a few weeks or a month thereabouts, the Ministry of Health also announced, I think during the protest, yes, it was around July, the ministry announced we also have a few cases in the country.
Yeah, now I remember that time. I remember that time. It was around during the protests. Interesting. So you've mentioned something, which I think also we'll expound later. Uh, the clinical presentation. I think from where I sit, I haven't actually met. Actually, I haven't met a patient with Mpox from where I sit, because much of my practice has been within Nairobi, even though there have been Mpox cases that are reported over there, but maybe the patient population never had. I've never had a patient population that is exposed to Mpox, and some of the presenting signs, because it's maybe from the virus group, probably will have fever. So a patient will come in, will have elevated body temperature or fever, and lymphadenopathy. That's something else that's normally present in Mpox. So some swelling on the lymph nodes. But I think what is particularly, how can I say, is it, I think I'll get to that data, but something characteristic for Mpox is the rashes that the patient presents with. So they'd have sort of macule papules, macule papules, vesicles, and some sort of scabbing if they've been there. So the secondary characteristics of those rashes, and they can be painful, but not necessarily itchy, but a bit painful. So your typical patient will come in, will have a fever, swelling on the lymph nodes, and when you look at their extremities, particularly in the hand, they will have these sort of rashes that have been there. They might be turned now to secondary characteristics where they have sort of pustules, sort of scabs, and that might be a typical patient coming in at the clinic. Yeah.
I think apart from the fevers, the headaches, the skin lesions, the rashes, the key distinguishing feature should be lymphadenopathy because the first time you see that patient before the lymph nodes are swelled, or swole, I'm sorry. You might confuse it with smallpox. You might confuse it with smallpox a bit. But the once you take a careful examination and you realize that the lymph nodes are actually blocked and therefore they have swelled, is when you'll be like, oh, this could be Mpox. Before, I'm talking about just the presentation before you even do lab test and confirm that okay, it's seropositive or something like that. Yeah. So transmission is through contact primarily. That is why, anyway, I'll come to that. Transmission is through contact primarily, all respiratory droplets, things like body fluids, sweat, sexual fluids, all that, what have you. That's why even in handling these mpox patients, the IPC, infection prevention control measures were similar-ish to COVID because it's a contact disease. So if you have, I remember there was a patient. I'm sorry, doc. Our hospital was handling these cases, working as a quarantine center. Uh, there was a patient who came to the hospital, and the suspected main mode of transmission was that the husband, who is a long distance truck driver, upon getting home, he had given this patient, she was a woman, his clothes to wash. So from the sweat and all that, or body fluids rather, I think she contacted. Yeah, because the husband was also, we came to realize also we need to quarantine the husband as well because the husband was also suffering from the same.
So
Yes,
in this case, the clothes were contaminated with the virus.
yes,
Yeah. Okay.
yes,
Mm.
yes, yes. So then, of course, there is sexual networks. So there's when you talk about prevention or public outreach, there's a need to also talk with the sex workers how to maybe maintain proper hygiene. If you have a patient who is married or they have a partner, you have to inform them on the same. Sometimes you have to seclude them or quarantine them from the partner if the partner is negative, but after also observing the partner for a few days. Maybe tell us about what's that? I'm looking for that term. Um, how soon do the symptoms present? Now that term.
Yeah, I haven't come into contact with like Mpox case, but from the way you are telling me, okay, let me just take up. From the way you're telling me is that number one, this is obviously we have said it's a viral infection, and the patient will present with fevers, headaches, rashes, swelling of lymph nodes, particularly, might be so characteristics of Mpox. I'm not sure of the, how can I say, how soon before the patient will present with the illness. I don't know if it's 5 days, 10 days. I haven't read the literature much before the clinical presentation. And that's something that I would really like to know. So then something else you've mentioned is that the transmission is more person to person transmission, mostly through bodily fluids. And this can be, for example, even in clothing, even in skin lesion, even through the sexual networks that happen. So that can be also important networks where this kind of transmission can happen. Yeah, on the how soon before the symptoms present, I actually don't know on that. How soon is it?
I think 30 days, if I'm not wrong. I think it's 30 days. Uh, before after contact, before now you start developing those symptoms. It's not 30 days, it's 15 to 30 days. Thereabout.
I'm seeing here that the symptoms usually appear 5 to 21 days after exposure, and I think now
Yes.
they can last the whole like for 4 weeks. So maybe that's 30 days now period. So in this case, maybe a truck driver comes into contact with another truck driver, gets Mpox. It won't happen immediately. The symptoms might not develop tomorrow, but might take that 5 days or even 2 weeks. Then the symptoms start appearing. And I think the reason why the symptoms might take 5 to 21 days to appear might be hidden within the pathophysiology of mpox, which I think is something that we can check later on and see, okay, how does this virus escape the immune response for it to take 5 to 21 days for it to manifest. I think that's something that I'll take back home as homework. Yeah. So something now important now that we are moving now into the angle of modeling, which is now where things such as Mpox, I think now are maybe important now for people in epidemiology and all that kind of stuff, is because there's this whole aspect of animal reservoir that now introduces an interesting element when you start to think about Mpox. So I'll just touch a bit about the animal reservoir component before now we go to the modeling bit. So although the transmission of Mpox we've mentioned, it goes from skin to contact from one person to the other, there's that element of animal reservoir. So in this case, the virus is not in circulation between human and human. But in between here, we have other animals, such as rodent species, that are considered potential reservoirs hosts of this condition. I haven't I don't know in Kenya. Okay, you mentioned something like primates when we began earlier on. So I think also primates are reservoirs. In Kenya, I think probably this might be in rodents, but I haven't seen it being linked to that at the moment. So I think this is where people in epidemiology can come in and maybe shed light on that. Maybe a word or two about that.
No, no, no.
Uh,
You've hit the nail on the head. Animal to human transmission occurs, and that's why I think the whole aspect of One Health approach to these to health management really matters, because you could get it through caging, just cleaning the cage, or even hunting some of these animals. I'm thinking about primates and sorts of rodents in the home. Hunting, yes, even hunting. You do appreciate? Yes, you do appreciate the different cultural
uh,
or background.
yeah.
Yeah, considering the whole of East and Central Africa.
By the way, that can happen. But yeah, come to think of it,
Mm, so it can happen. So there's the touching, just or processing meat from these animals, bites, scratches, what have you. Yeah, yeah. That's how animal to human transmission occurs. I think one thing we forgot to highlight is the most affected group is the immunocompromised. Oh, yeah, and it's compromised patients. Yeah,
Mm,
uh, that's why for those with whose immunity is okay, some of them or most of them will develop even hard immunity once they are quarantined, and then they get better, because all you have to do is maybe manage the pain, the fevers, just managing these symptoms. And then the immunity, of course, takes over, the immune system takes over, and the patient heals or recuperates. For the immunocompromised, it's a whole different story.
mm,
Uh, uh, yeah, it's not so.
that's interesting. I didn't even remember because now again that takes me back to takes me back to pathophysiology, and yeah, I'd like to see how this virus acts in that immunocompromised kind of uh, patient profile. To be interesting to see how the presentation is like, even in that setting. So that's also something to take home for me to review.
Mm. Because if you think about it, if it attacks the lymph system, the lymphatic system, and the role of the lymphatic system in the whole immune system. So you maybe
When you said lymphatic system, and when we were talking about lymph nodes, I was thinking in my head, okay, what other differential diagnosis might come in this picture? So also another point of reviewing that I think is worth reviewing for me. Okay, so let's go over now to the modeling side and introduce now why modeling in this particular case is important. We've talked about different things. We've talked about the where the disease reservoir is, how the transmission happens, how the transmission happens even from these reservoirs, and we've talked about interesting patient networks and interesting patient populations that might even be affected. So how would you say, or what would you say a model? If a medic walks to you and asks, look, what is a model? I know it's a quite a general word, but what is a model? What's the simple analogy of a model to you?
I'm not the best at definitions. You're putting me on the spot, but I'll try. It's a it's a it's a mental heuristic, if I can use that word. It's a mental heuristic where you want to take all variables possible and then imagine. It's like okay, I want to forecast. I don't have the data to forecast. Okay. What I have is past data. I do not have future data to be able to say, okay, this is what might happen in this case or in this scenario. But you have this heuristic. You know how this infectious disease works. You know maybe the geographical information of this disease, where it occurs, and the number of people at a particular setting, if there was an outbreak, how it's transmitted.
Hmm.
Then you are like, okay, so this is possibly how it will go. And then you also have interventions in mind. Maybe if, for example, COVID, we dealt with it through vaccination, through quarantine, all these manners of intervention. So you're like, so with all this, how can I project
Yeah.
this disease? Yes,
Mm.
yes. It's a heuristic of sorts.
Yeah, so a representation of
Yes,
what the real world will look like. And I think one thing
yes.
you've also mentioned in there is that there is some sort of data that is happening around there. So when you talk about the counts, so over here, for example, what you have looked at from the paper, from this newspaper, is that they've presented the counts. They've said these numbers and these numbers and these numbers. And now what we're asking ourselves is models within this space of mpox that exists that maybe try to articulate or bring out different heuristics or different representations. How then would they look like? What form would they take? I know there's a whole field dedicated to disease modeling called epidemiology, but we are also seeing some interesting interaction with machine learning, with AI. And now we're asking ourselves, okay, how does modeling look like in this space? And now, given the context of epidemiology, and a good example now here is Mpox. So
Uh,
mhm. I had mentioned
just finish.
SIR or SIER in short, and
The foundational model. I love that model.
so
Uh-huh.
so and when you mentioned like COVID, so I was like, okay, it falls within that SIR model. So when you talk about SIR, these are like compartment models. So in essence, they fall under a group called of compartment models, which are mathematical frameworks that simulate how populations move between how one is susceptible to an infection, how one is infected, and how one, for example, recovers from from a disease. So in this case, the SIR model is sort of a compartment model that represents these population groups or patient groups that move from one section to the other to the other. Mhm.
So we have different types of models. We have compartmental models, which is the SIR and its variations, which will include maybe exposure, where you have SEIR or SEIR. You have all sorts of variations. You have vaccinations, which is SVR or SVIR. And then you have also agentic modeling, and other types of models. Maybe in another section, I'd really love to talk about some models. But for now, we can talk about compartmental modeling for Mpox, which is now we could go with the SEIR depending on the nature of the disease. Sometimes sometimes the exposure compartment is included or excluded depending on the nature of the disease. So you have the susceptible compartment where you have all these patients who are susceptible in a certain geographical area. For example, we have talked about how Mpox was being transmitted to Kenya. It was through the transport corridors. Okay, the whole Mombasa to Malaba highway, all that way. So you could take all these patients along those towns or those uh, cities or whatever.
The counties.
They could be, yeah, counties. Those are susceptible patients. Then there are now those who are
Who
exposed.
exposed,
Those who are
yeah.
actually,
The truck drivers
yes,
now, maybe in this case.
exactly, or even their families. Okay.
Mm, mm,
Then now you have the infected ones.
Oh, yeah, yeah, yeah.
Yeah, those who have now been infected by this disease. Then you have the recovered ones who you hope, depending on the disease, not you hope, depending on the disease, some of the recovered ones cannot be infected again. They have gained immunity, and most infectious diseases are by then they are like this. Or upon vaccination, they gain immunity, and then in some diseases, even the recovered could as well still be susceptible. And I don't know, is tuberculosis a good example for a recovered patient who could still be susceptible again?
Yeah, but there's that period. Uh, I think when a TB patient is cured, the relapse for them maybe to have a recurrent TB might involve other factors. It's not really as straightforward as maybe viral
I'm going
infections.
I'm gonna ask you, Doc. For example, you contracted TB and then you've been treated through the whole 12-month, 24-month phase or 16-month phase. If I took you to a geographical context where TB is high and all that, and then you get exposed, could you be infected again?
So now that will be dependent on the immune system, because given that you are not again immunocompromised or something like that, then you shouldn't be able, you shouldn't get TB again during that period. I mean, it's really a very short window for that to happen. Yeah.
Mm.
I'm trying to imagine a case where that would happen. So maybe a reinfection of TB for me, I'd say, would happen if a patient is maybe severely immunocompromised after even completing a whole TB regimen. Then, or a case of even I don't want to say it, resistant TB or multi-drug failed TB. So maybe that again would bring that element of reinfection. But in this case, if in the case of TB, then the burden will be more so on the immunity rather than the infectivity of the TB itself.
So. I think that's quite covered. So yeah, we have all those compartments and anything from your end?
Yeah, so I think from here, I think what we are seeing, that the best kind of models that people are using are sort of these compartmentalized models that would maybe best try to describe the evolution of mpox within a population. And in this case, we've said there are people who are susceptible, the people who are exposed, the people who are infected, and the people who have recovered. And I think now this goes to the earlier point where we are mentioning how long before you have mpox do you get the symptoms. Remember, I said around 15 to 5 to 21 days. So yes, so before this, within these 5 days, maybe you might be exposed. Actually, you actually might be infected, but the infectivity rate is not that much for you to transmit mpox in this case. So I'm trying to see the clinical representation plus the population representation and tie the modeling on how this can happen over here. And there is also that additional component of a reservoir, which now makes us think, okay, do we want to consider this reservoir within our modeling frameworks? And is this dependent on specific patient populations and all that kind of stuff? And I think this goes to show how models shape our understanding of healthcare, even just beyond epidemiology. Because models are normally just not for outbreaks. It's not that when we have an outbreak and then we start thinking, oh, where is our model, or how does our model look like? So models in this case are normally important for resource allocation. So in this case, I'd imagine resource allocation for people who are susceptible to Mpox need to be catered for because there are maybe hot zones in this case. So think about bed occupancy in hospitals. Think about ventilators. You've mentioned your center is it's a quarantine zone. So I'd imagine that the resource allocation cater for these kinds of needs, where even in a case, maybe for example, we're having vaccine, the vaccine distribution is catered for. They're called chain supplies. So modeling helps you prepare for this by creating that resource allocation. Something else I can mention is maybe the diagnosis strategy. So in this case, do you have a strategy for screening? Do you have a strategy for testing of this patient population? We've said there are truck drivers at border points. What are the strategies set in place for us to do this testing at these points? Because what ends up happening is that that data ends up feeding the models. And when they feed the models, now the models continuously present this realistic or close to realistic heuristic of the real world. So the more data points you're able to pick up, either by diagnostic strategies, feeds onto the model, and this model moves closer and closer to how well they represent the real world. Mm.
Maybe one more thing before we forget is you want to also see what is the desired, or rather what is the not desired, I won't call it desired, but what is the threshold before those who are infected start getting herd immunity. This is something called you have to determine through something called the basic reproduction number. I'd say it's the number of secondary infections that occur from one primary uh, infected person, or contact with an infected person. So I touched on in another setting. I've written on bifurcation models, or rather bifurcation methods, when it comes to assessing these basic reproduction number, where it's sort of a threshold where you have if, for example, you were to draw it on a Cartesian plane and you have x and y axis, I'd say assume a basic reproduction number on x equals to 0. So to the right, you have uh, absolute spread of the disease. To the left, you have containment, which is the negative aspect. You have containment of the disease. So these x equals 0, would be your basic reproduction number, a threshold beyond which you'd be able to determine, okay, maybe past this, we have a lot of infections and we cannot contain it. And maybe below this, we through maybe vaccination, through other treatment strategies, or through other interventions, maybe isolation, we can be able to contain this disease. So once you determine that reproduction number, you can be able to even do things like resource allocation, which I've been talking about. Yeah.
Yeah, that's an important point because it really helps us establish that baseline, which might look even different for different populations. So I'm guessing in other resources in other areas, that basic reproduction number might actually look different based on what's happening and other factors that influence those numbers. Yeah, that's an interesting, and I think that also ties to the behavioral and social dynamics of things that actually influence models. So, for example, I'd imagine that in an area that has stigma, what will this stigma maybe influence this basic number for this model? For example, areas that have vaccine hesitancy, what would it even influence in this case? In this case, even something as misinformation spread. So yeah, those are very important things to keep at the back of your mind when figuring out, okay, my model numerically looks like this, but okay, what makes this number rise or sit down before I say, okay, let my model start running or start modeling this environment.
Thank you. Yeah, yeah, that's a very good point, by the way. It's not all facts and figures. You also have to take account of the cultural setting of your people, because around that time when the Ministry of Health announced that we are seeing a few cases of mpox, and they got out a circular of next steps for the citizens. What should we do? How should we be on the watch out and stuff like that? Once they pronounced vaccinations as an intervention strategy, we saw a few, there was a few squirms from the people, those who are vaccine hesitant, and those are some of the things that you have to sort of take into consideration when you're coming up with your model, right? You cannot assume 100% vaccine efficiency or effectiveness, because there are some groups of people or patients who will say no to vaccination. And then that will now influence your reproduction number. Remember, you want your basic reproduction number, or R naught, to be equals to 1. So if it's over 1, the disease becomes endemic, and it blows up on your face. Below 1, that's how you can control it, you can maintain. So even for those who, what you're saying, social behavioral uh, uh, considerations, for those who are hesitant to vaccination, what do you do? Can you quarantine them? Can you isolate them? Do you hospitalize them? Stuff like
So now that you're mentioning that, so I'm seeing here when you're talking about even just modeling mpox, we are not focused on the epidemiological model like SEIR model. Boom. So what we need to think of is, okay, what are the behavioral models looking like? What are even the health system models looking like? The network models would be the sexual networks, the household transport networks. What would it look like? At this moment, I don't know if I know this is one area you love. We don't know if a sort of genomic kind of model that keeps. Oh,
that.
actually, we've mentioned we've mentioned the clade 1B, clade 2. I think also there has to be a model for that. So even how the disease moved from clade 1 to clade B, because I remember COVID was mutating at some point. COVID was mutating so fast between different variants, and these different variants had different spreads. So even though we have an SRI model for COVID, we have to keep track of the genomic variants of COVID. So again, how would that model even look like? So there's a wide variety of models to keep track of, and it's important to understand which parameters drive these models, which kind of data sets help you figure out where to plug in for this kind of models. Yeah.
Yeah, so you've mentioned in terms of the epidemiological models. There's that aspect where you're looking at the compartmental ones. You're looking at genomic models. You're looking at network models, spatial models, which is now the county level or geographical level. You have looked at behavioral models, where you've looked at where you've mentioned uh, perception, perception by the community that you're handling, right? Uh, we have the health system models, where you're looking at capacity. Does these hospitals have the capacity to even handle these patients? If they do not have that capacity, and you still cramp up all these patients in one facility, it will blow up again on your face. Uh, there's also the aspect of interventions. I want to talk about that a bit. You have single strategy interventions, you have double strategy interventions, you have multi strategy interventions. So, single strategy is where you're like, okay, maybe we are a low resource country, we are a low resource county, we are a low resource district, whatever it is. We're just going to approach this thing from the isolation point of view. Okay. Then you have or quarantine, or you just take one intervention and you run with it. Then there's the double strategy where you're like, okay, for these ones whom we have isolated, we are going to vaccinate, right? So those are some of the how can I term this interventional approaches that you can take. For those who you have isolated, you vaccinate, and then that's that. Then now there's the multi-strategy interventional models where you're like, we will isolate, we will vaccinate them. Uh, Apart from that, we'll also do public education, right? Where you inform the public this is what is happening, and then there's also you can also incorporate IPC where it's infection prevention and control measures, like if it's through respiratory droplets, kindly wear a mask. If it's through contact, please wash your hands every now and then. Do not touch surfaces anyhow and stuff like that. You have to incorporate all these methodologies into your model so that it can be more realistic. Remember what you said, representation of the real world setting.
Mm.
So yeah. So you want to mimic the real world setting as much as possible through a mathematical model. Yeah. So
Yeah, there's this aphorism by George Box. It's a famous one that says all models are wrong, but some are useful. So, so you really need to get the ones that are useful in this case. So as we go to the tail end, there's now this whole aspect of AI. So we've mentioned these things. Now I'm seeing where maybe AI might come through, and I'm thinking, okay, given that you have many models to consider, and now I'm telling you, okay, consider even AI in your model, then what does the conversation even start looking like in this case? Uh, Sort of AI enhanced kind of precisions to aid these models. And for AI, they sit on a machine learning. So in this case, is it ML for parameter estimation? Are you using a neural networks to estimate, for example, the R naught from noisy surveillance data? That kind of thinking. So in this case, how would that even happen? Something else would be even in this. We sort of mentioned them. We sort of said by behavioral models, or like the one during that time of let me say maandamano, in this case of protests, when we are saying that the public took it differently. So this represents that kind of NLP, that kind of social media mining. So in this case, can you use AI to get that kind of context for you to do something with this model? Hmm.
yeah, for sure, for sure. Remember, there's what we didn't touch on. Like when you're modeling, you're simulating, right? And when you're simulating, you need parameters. For example, if you are talking about number of patients, what's your ideal number of patients? How do you estimate that? How do you estimate something like from the compartments? How many days does it take for a susceptible patient to be infected or to be exposed? Then from exposure to infection, from infection to recovery, there's the vaccination waning effect. We have vaccinated you, but how long does that vaccine actually remain effective in your body, and when does it wear off, and does it then make you again susceptible? So, and how many days does it take you to recover without vaccination? So these parameters that we are talking about, you need. I think machine learning will come in handy there for parameter estimation. You'd maybe consider neural networks to estimate even a basic reproduction number that is ideal from your data. Remember, you have past data, you do not have future data. So all these scenarios, for you to get a near accurate estimation of sorts, machine learning will come in hand there. So yeah.
That's true. And also, I think that from that point of simulation, then I'm seeing the case of generative AI coming into play and sort of trying to tease out these scenarios. So if we close this border, what happens to Mpox? If we increase this testing here, what happens here? And I think also this plays into the strategy that you are mentioning. Generative AI can help tease out those kind of strategies given the resource that you have as an intervention for intervention. So I think that's also somewhere within this enhanced Gen AI epidemiology for Mpox could play out in this case.
Yeah. So things like even reinforcement learning in ML AI will come in handy for resource allocation. We're like, okay, um, maybe this area needs more vaccination because the last time we vaccinated them, we saw the numbers really drop and it worked. So maybe these hotspots, counties or areas need more vaccines. So let's allocate more resources. What was this county? Yeah.
Okay, I think that says me a lot about Mpox that we've covered. We've started from all the way from the headlines and what the headlines have told us, and from the headlines, we see that deaths are rising. 4 out of 7 recent deaths have been from Kenya, and these are sort of like the signals that are happening out there. And we've now reviewed all the way from how the presentation is like. I think the only thing we have not touched on is on management, but that's for another day. But anyway, we've talked about the presentation, then we went about the public health of things, especially in the current counties, how it's happening across borders, across the truck drivers, even the sexual networks, even down to the household transmission of Mpox. And we even talked about the reservoir and then went further and now looked at it from a model perspective. So in this case, we are like teasing out how models would look like. We didn't go deep into the maths of things, which again, that's another topic for another day, but you are able to see how SRI models work in this case. So SRI compartment models, how they play out, how we can even add the aspect of exposure in this case in an SRI model. You hinted about something like agentic models as well, which also come into play within this context, which is something very interesting. Then beyond that, we saw sort of some strategies that can be used in this case. And we also saw something interesting that I really loved were other variants of all types of model beyond that, just beyond the epidemic one. So spatial models, behavioral models, health system models. How can this play to reinforce this compartment SRI kind of model? And my favorite, which I know we'll be talking more and more as we go along, is how can we bring AI into this picture? I think that's something that we're looking forward to discuss more and more as we go along. Any closing words or something that I've missed out?
Um, no, so I'd say it's a very important thing to keep in mind that not all medics need to be modelers, but we need to bring in modeling more and more into our public health field. Let's take these tools into practical consideration where we get to see at least near accurate representation of the real world settings. It will go a long way to help us anticipate for anything really. And maybe one thing I'd add from our discussion, we if you are the around best practices of modeling, you have to maybe take care of other variants from household transmission. Uh, the vaccine effects that I mentioned about, you remember we had a supply chain issue uh, pertaining vaccines in general, not Mpox vaccines, but vaccines in general in the country. Yeah, the CS for health at some point had to flag off vaccines once they came into the country just to assure people that hey, the government has got you. But we suffered for like almost 3 months, yeah. So in your model, what happens when you have isolated or quarantined the patient and they're waiting for vaccine, but the vaccines are not there? Uh, we'll look in the future, in our, of course, future iterations or podcasts, how we are going to incorporate simulations and AI into modeling and not just example. Yes.
Very well, Daktari. I've loved this Mpox. I think I've remembered some things that I didn't knew were inside my head. And also, I've seen some important notes to take back home and revise. And also looking forward to discussing it with the AI. So we are also looking for people within the space, epidemiologists, statistician. If you are interested in this kind of conversation, let us know. Yeah, and see you in the next episode where we talk about medicine, data science, and everything in between. So make sure to like, share, comment down below, and also subscribe to all our social media platforms, YouTube, Instagram, and LinkedIn as well.
Peter.
Also Twitter. Yes. So until next time to our audience, it's been your host, David Andai, and none other than Daktari wa Pwani si Kenya, Dr. Clinton Osebe.
Asante.